Hello, everyone. Welcome to today's live broadcast, Social Determinants of Health, Impact on Pharmacy in 2020. We are pleased to bring you this webcast presented by Drug Topics and Managed Healthcare Executive and sponsored by LexisNexis Risk Solutions. Lexis Risk Solution combines, analyzes, and delivers data and analytics to optimize quality, performance, and impact across healthcare entities. Their solutions leverage the industry's most robust and accurate socioeconomic and provider data, comprehensive public records, proprietary linking and claims analytics, predictive science, and computing platform to transform the business of healthcare. For more information, please visit LexisNexisRisk.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found in the middle of your screen. You can enlarge the slide window by clicking on the small square icon in the upper right-hand corner of your slide window, or by hovering your mouse over the right-hand corner and dragging the window to the desired size. The slides will advance automatically during the event. If you have any technical problems viewing or hearing this presentation, please click on the question mark Help widget at the bottom of your presentation window. And I'd like to introduce today's speakers. We are pleased to be joined by Rich Marino and Aaron Benson. Rich is part of LexisNexis Risk Solutions Healthcare Strategic Clients team. In his current role, he provides industry and solution expertise on such topics as improving healthcare outcomes, reducing the cost of care, and enabling consumerism. Aaron serves as LexisNexis Healthcare as Senior Director, Market Planning. Her focus is on the development and execution of strategic planning for member identity and socioeconomic determinants of health solutions. Thank you both for joining us today. Rich, please get us started.
Thank you, Amanda, for that introduction, and thank you to everyone viewing this webinar live or via recording at a later date. There's a lot of buzz in healthcare about the use of social determinants of health information. For this webinar, we faced a dilemma. On the one hand, we could talk about the use of social determinants of health data in healthcare for days. On the other hand, we had slightly less than an hour for today's webinar. So in order to distill it down to a useful and brief webinar, we chose the agenda on this page. SDOH, the impact on quality ratings and reimbursements, best practices in workflow, and leaving some time for Q&A. So let's get started. This is still a lot of information to cover in a short amount of time. Now, social determinants of health is a very broad topic, and many institutions suffer a bit of paralysis by analysis when trying to deploy social determinants of health across their entire enterprise. So rather than summarize all the potential uses of social determinants of health in pharmacies, we're going to be more focused on today's presentation and discuss how they can be utilized specifically to improve quality ratings, improve outcomes, and reimbursements. To begin, let's spend one slide talking about the entire healthcare industry's journey towards measuring quality. Fee-for-service, the old grocery store model for healthcare, was our genesis. In fact, by most estimates, it still accounts for 40 to 60% of all healthcare transactions today. However, over the last 20 to 30 plus years, there's been a migration towards paying for quality rather than quantity. Now, this was largely driven by the payer market, where increases passed along to employer clients led to demands on proof that their money was being spent wisely. These initial efforts at moving from quantity to quality wound up being called pay for performance, and were largely based on processes. For instance, did a breast cancer screening occur? This phase also saw NCQA start building out HEDIS measures, which are widely used in the payer market for Medicaid, Medicare, and commercial audiences, and then CMS, or the Center for Medicaid and Medicare Services, which built out STAR, from Medicare health plans and prescription drug plans. Pay for performance evolved to pay for value, largely because the rewards for performance were so late and retrospective as to not influence any behaviors. Oftentimes, a physician received a performance bonus months after the desired behavior occurred, meaning the physician had no recollection on why they were getting a bonus and what behavior they should continue. Paying for value now includes alternative contracts, which I'm sure all of us on this webinar have heard of. And in alternative contracts, there is both significant upside for high quality, but also downside for poor performance. These contracts expand beyond the traditional payer and provider relationships to now include dispensers and manufacturers. And what is being measured now is much more comprehensive, including preventative measures, satisfaction scores, and performance measures, such as readmission scores or medication adherence post-discharge. This brings us to how clinical quality impacts the pharmacy market specifically. Somewhat oversimplifying it here, but it starts with the Center for Medicare and Medicaid Services and their STAR measures at the top of our waterfall, or left side of this slide. Within STAR, there are 5 domains, which are basically categories, specifically assigned to prescription drug programs, and another 5 assigned to health plans, which we really won't cover during today's webinar. We will cover the prescription drug plan domains in more detail in the next slide, though, and the yellow bucket on this slide has the 4 domain names. Now, at the bottom of our waterfall of measures are pharmacies. Early on in pay for value, it was understood that pharmacies have to have skin in the game as well if we want to impact patient outcomes. In order to gain alignment with STAR measures prescription drug plans are measured on, the PDPs and pharmacies developed performance measures. Now, on this slide are 6 common categories as defined by the Pharmacy Quality Alliance, and what you'll see is that they wind up being very similar to what STAR put in place on top of our waterfall. The clear intention here is to drive alignment from CMS through prescription drug plans to pharmacies. So there is a common view on what should be measured and how to define quality. And that brings us to today's first polling question. Amanda?
Great, thanks, Rich. I'd like to now ask our audience to participate in our first polling question. So please click directly on the screen to submit your answers. And here's the question. Is your organization using social determinants insights today to improve value and quality ratings? Is your organization using social determinants insights today to improve value and quality ratings? So now we will hear or see the poll results. And it looks pretty even. Rich, would you like to explain?
Thanks, Amanda. So we're seeing here about 20%, yes, we use social determinants of health insights. Another 30% examining to possibly potentially use. And then a preponderance of folks who are still assessing how they might be able to get value out of that. And that's really kind of reflective of the market. There's a lot of information available for social determinants of health, but as an entire ecosystem here in healthcare, we're learning who is responsible for what and how to best leverage it. And I'm hoping that as a result of today's presentation, you walk away with some tips on how pharmacies could best utilize it. Which brings us back to our conversation. So we talked about the waterfall and how CMS had developed STAR ratings. And there are 4 quadrants or 4 domains for STAR. And the slide you're looking at right now, there's some quadrant art on the left side, and you'll see those 4 domains. For 3 of them, it's mostly measures that are collected at the prescription drug plan level. However, the 4th, drug safety and accuracy of drug pricing, is more complicated. On the right side of the slide, you'll see the actual measures under the drug safety and accuracy of drug pricing domain. The medication adherence measures, the bottom 4, are based on whether eligible patients had 80% of prescribed medications filled. Obviously, field's the only thing we can ascertain, as we don't have the ability to see whether or not they actually take those medications. Now, in order to be successful in these measures, you really need to predict, not react, who might be at risk for being out of compliance. This prediction requires more than collecting data on whether an event happened, and the prediction is really only the first step. The second step is an understanding of why the patient might not be in compliance. Only with those first two, who is at risk and why are they at risk, can we then move to the third step, which is aligning some type of service that coordinates and removes the potential barrier to medication adherence. An example of this is maybe identifying and supplying non-emergency transportation to a socially isolated senior to help them pick up their prescription. So earlier we saw a preview of the 6 categories of performance metrics as determined by the Pharmacy Quality Alliance. Now, each of these has their challenges, but for this webinar, we're going to focus on what can be done prospectively that can have a significant impact on scores. So now we've gone and highlighted 2 of the 6 buckets. What we've found is that predictions are highly useful on medication adherence and motivation to attend a comprehensive medical review for medication therapy management. In fact, they may be the secret sauce that moves the needle on quality scores and outcomes for patients. Going one level more granular, for adherence measures, we are trying to predict not just who might not get their scripts filled, but also gain insight into why they won't get them filled. This understanding of why is critical for to align those services we discussed to improve their adherence rate. Now, later in this presentation, Erin will show you how why can be serviced in a workflow. I'm going to give you a quote here. Part D sponsor must establish an MTM program that ensures covered Part D drugs are used to optimize therapeutic outcomes through improved medication use, reduces the risk of adverse events, is developed in cooperation and with licensed and practicing pharmacists and physicians, and may be furnished by pharmacists or other qualified providers. In English, this means you need to bring in chronic condition or at-risk patients to review their prescriptions and medication plan. Key to performance on this measure is determining who might not come in on their own and if there are any identifiable barriers that can be addressed that will improve their chances on attending. A predictive model that identifies who is motivated to participate in managing their own care can segment and identify those who are at risk for not coming in for a medication therapy management session and why they're at risk. That brings us to today's second polling question. I'll toss this over to Amanda.
Great, thank you. So we do have our second polling question. Please click directly on the screen to submit your answers. Which pharmacy performance metrics do you think social determinants insights can help improve the most? Which pharmacy performance metrics do you think social determinants insights can help improve most? Adherence, appropriate medication use, medication safety, medication therapy management, monitoring measures, quality improvement indicators, or all of the above? And our results are now in. Actually, all of the above. So Rich, can you explain?
Sure. I think the audience has quite rightly recognized that there is the issue in regards to clinical data and that it does a very good job of understanding who is clinically at risk. But there's evidence for the right condition, medication adherence, monitoring measures, quality improvement indicators, that not all factors are the same. For instance, a pharmacy can provide the same level of care to make sure they're providing the appropriate drug to the individual every time the prescription is filled, but that doesn't necessarily mean the individual will always take it or come to the pharmacy to get it. There's a lot more that goes into medication adherence than the quality job being provided at the pharmacy, such as whether or not someone has the economic ability to afford the drug, has the transportation to go ahead and get it, and several other factors that can be identified through social determinants of health. And that's why there is many possible ways social determinants of health can make an impact on pharmacies, but specifically identifying those that impact quality rankings and ratings can both benefit the pharmacy itself as well as the patient, which is why we've chosen to start here first. With that background in regards to social determinants of health and their ability to make an impact on clinical quality ratings, I'm now going to turn it over to my colleague Erin to talk about best practices in workflow.
Great, thanks Rich. That was a great overview on all the different places that social determinants of health can really help to improve quality ratings and performance metrics. But in this next section, we want to go into a little bit more detail on how to best make social determinants of health data work in day-to-day workflows, as well as some preliminary steps that we've found to be helpful for pharmacies and PBMs that can help to improve patient engagement and medication adherence. It really all starts with what you know about your patients. As a pharmacy benefit manager, a specialty pharmacy, or a retail pharmacy representative, there are a few key questions to ask yourself to get started at improving quality ratings, medication adherence, and patient engagement. First, I would recommend you ask yourself, am I confident my organization can match all of the patient's prescriptions and other records back to the right patient every time? If you have a sophisticated system for assigning a universal patient identifier, the answer might be yes. But if you have any doubts, coming up with that one source of truth on each patient is an important first step to ensuring you can best help that patient. Cleanse your record database so that each patient's information is in one unique record so it is accessible to your pharmacists and other care team members when they go to help that individual. This will ensure that social determinants of health data also ends up in the right place. Second question is to ask, is my organization able to support our patients throughout the changes in their lives? Do we have the latest contact information for them, such as after they move? If you have ways of regularly updating demographic information, the answer might be yes. But if you suspect you might have outdated information in your systems, update that contact information to ensure you can best help that patient. You have to be able to reach them to help them with their social determinants. The third question to ask is, do I understand my patient's social determinants of health well enough to know how they are impacting medication adherence or other health outcomes? If you have a clear understanding of what in your patients' lives are influencing their ability to be compliant with medications, you're in great shape. But if you need a little help with this, and it sounds like from our poll, a lot of people are looking for places to get started, a good next step is identifying how to predict who is likely to need help based on their social determinants and what kind of help they may need so that you can help them improve their health outcomes. The first two steps will make you more successful at addressing social determinants of health in the third step. So we'll look at each of these steps, cleanse, update, and improve, in more detail next. When pharmacists consult with a patient about a prescription, they first need to be able to identify if that patient has an existing record. If they're unable to locate an existing record, the pharmacist is likely to create a duplicate record. The reason they couldn't find the existing record is often due to things as simple as the existing patient record contained incomplete or inaccurate information, like a middle name wasn't entered or there was an out-of-date address. And a lot of this has to do with whether or not there are standard techniques for inputting the data to begin with. Regardless, without an updated and accurate view of the right patient's complete and accurate history, the pharmacist can't consult on the case with complete confidence. Before you can address an individual's social determinants of health, you need to have a complete view of their situation and have confidence you're tying the right information to the right individual. With millions of transactions coming into the pharmacy and e-prescribing continuing to grow, it's becoming more and more critical for pharmacists to automatically access these records. The Institute for Safe Medication Practices estimated that 7 wrong patient errors happen on average every month in every U.S. pharmacy. And it's no wonder when you consider the average health system has 5 to 10% duplicate records on average, and that number increases upwards of 20% when there's data sharing across organizations or an organization has multiple facilities. There have been cases where patients have shown up to the pharmacy, received a prescription for someone who had the same name, taken that drug, and then had adverse side effects because it wasn't meant for them. In other cases, patients haven't been informed of potential drug interactions because their prescriptions were stored in separate files. Duplicate records may seem like only an administrative issue, but they sometimes have life-altering consequences. By assigning a unique identifier to every patient record, you can match and deduplicate records that come back with the same UPI. Ideally, this identifier would be assigned based on extensive referential data and sophisticated linking technology to ensure confident matches and be accepted as a standard UPI by the National Council for Prescription Drug Programs. Having an individual's information all in one place makes it easier to track a patient's information over time and engage him or her in consultations or prescription management and treatment programs. This can improve patient safety and simplify administrative processes, which in turn can lower costs. Once you have a comprehensive view of a patient's data, you can move on to making sure that information is up to date. I'll turn it back over to Rich so he can tell you more.
Thanks, Erin. Earlier, I spoke about the need to predict who might be at risk and understand why they're at risk so you could coordinate a resource to improve their adherence rate. However, even the most accurate prediction in the world will fail to impact patient outcomes if you're unable to reach the patient to coordinate their care. Oftentimes, contact data collected at the time of enrollment or at the physician's office has changed or is incomplete. Now, this leaves little wiggle room when quality measures are not only scored on the outcomes, but if you reached and engaged enough of the eligible patients. So let's spend a minute talking about the challenges of reaching enough eligible members to get measured. Every year in the United States, 45 million people move. 6 million people move out of their state. Now, 40% of these people never notify the post office they moved. Moving on to name changes, divorces, and marriages, 3 million changes in marital status each year. 50,000 applications for name changes. Almost 4 million children are born, and 2.5 million people die annually. Not all these are reported to the Social Security Administration. There's close to 400 million active cell numbers in the United States and close to almost 1 billion total numbers overall. And there are 21 million employment changes annually. Now, on the upper left box of the slide, you can see the requirements for comprehensive medical review for medication therapy management. Shouldn't be too hard to imagine your pharmacy being measured on how many eligible patients you can complete the CMR medication therapy management service. Now imagine your patients have the same contact problems we often see amongst the medication population at the far right of the yellow box in the middle of the page. This is 40 to 50% inaccurate phone and address information when you are trying to reach out to them to coordinate getting them in to do a medication therapy management program. So if you're not able to clean up the enrollment contact information prior to reaching out, your odds of bringing in enough patients for the medication therapy management to demonstrate a quality score is very low. Erin, I'm going to pass it back to you now.
Thanks, Rich. So now we'll talk about that third step in successful patient engagement, which is improving patient outcomes using social determinants of health insights. With the overall shift to value-based care in the healthcare market driven by government regulations and consumer demand, pharmacies must be able to determine the patients who need help, weigh their motivation to change, and then provide them with the tools they need to do so. Social determinants of health, including information on relatives and associates, assets, trends over time, neighborhood and household characteristics, and more, can be utilized to improve care management and risk stratification activities. Social determinants of health insights can predict who is likely to adhere to their medications and who is motivated to care for their own health. Additionally, and what will be truly transformative, is social determinants can provide insights into the types of barriers individuals have to being adherent so that they can be addressed proactively. In fact, one study found that 68% of patients reported at least one socioeconomic challenge that may be impacting their medication adherence. This included financial insecurity, isolation, housing insecurity, transportation trouble, food insecurity, and health illiteracy. Addressing these social determinant barriers can occur at an organization-wide level, as well as with individual patients at a pharmacy or in a plan. At the corporate or plan level, you can use social determinants of health insights to segment your patient population into groups based on risk and identify the frequency and density of health barriers related to social determinants within those segments. You can then make decisions about programming and resource allocation across regions, districts, and store locations to address the varying needs, or have a better understanding of the risk within a population based on social determinants when entering into value-based contracts. This is what we refer to as acting globally. You can also act locally. With the right programs in place at the organizational level, along with an understanding of each individual's specific social determinants of health, pharmacists can help each at-risk patient get help from the programs or community resources best aligned to his or her needs. For example, when consulting with patients, asking questions that go beyond the prescribed medication can help pharmacists identify social influences that might be affecting adherence. For example, transportation issues may keep a patient from getting to the pharmacy to pick up their medication. Medication adherence is also often harder for patients in high crime areas because they often have less access to nearby pharmacies. Having access to social determinants information may prompt the pharmacist to schedule a ride share to get to the pharmacy or home delivery to make sure that individual can get their medications. This more holistic view of patients than just their medical or claims history helps drive the focus on quality and improvement in health needed to optimize financial outcomes under value-based care initiatives. Now let's look at an example of how a predictive score based on social determinants can be utilized in a workflow to improve medication adherence. These types of scores and alerts can be provided directly to pharmacists and care managers to help them quickly see the impact social determinants of health barriers could have on their patients and how to help. In this scenario, we have 4 gentlemen who are approximately the same age and have been prescribed medication for the same chronic condition. Statistically, 20 to 30% of prescriptions are never filled, and 50% of medications for chronic diseases are not taken as prescribed. Without any claims history, traditional medical care would tend to treat these 4 individuals as though they have the same risk level for medication non-adherence. But when we look at their social determinants, it helps explain why their risk is different. Within a pharmacy management system, a medication adherence score can be presented to a pharmacist that predicts the likelihood of each patient to adhere to their medications based on that individual's social determinants of health. So as you can see here, our patient Jack is only likely to adhere to his medications 25% of the time, or a fourth of the time. He has the highest risk for non-adherence, although Monty, and to a lesser extent Will, also have some social determinants challenges that raise their risk of non-adherence. Given that 80% or above is considered to be adherent by industry standards, as Rich mentioned, we would want to see what insights into Monty and Will's social determinants reveal about the care plan each may need. Looking at individuals who are closer to the 80% adherence rate can be especially helpful for improving quality ratings around medication adherence because small care changes may be able to help these individuals just south of 80% adherence to reach that desired level more quickly. Then we want to look back at Jack, who has an extremely high risk of not adhering to his medications. He may need a more in-depth care plan or medication therapy management. Looking at his specific social determinants can help us understand more. When we look at the social determinants for Jack that are creating his biggest barriers to medication adherence, we see the top 2 are related to economic stability, income, and overall financial health. This may prompt a pharmacist to have a conversation with Jack that can see if he's going to need help paying for his medications and then suggest financial assistance programs. He also has an indicator that social support might be a challenge. For example, studies have shown that the individuals whose nearest relative or associate lives more than 25 miles away from them are less likely to adhere to their medications. In this case, Jack might need someone to check in with him more often or have medications delivered to him if he isn't feeling well enough to pick them up himself. Utilizing social determinants of health insights, pharmacies and PBMs can partner with community resources or build programs in-house to address their patients' needs. Now that we've discussed some of the uses of social determinants of health in the pharmacy market, let's open up our last poll for today to understand more about how organizations like yours are thinking about using social determinants of health data. Amanda, can you open our last poll?
Sure, thanks, Erin. So we just want to remind our audience to participate in the final poll by clicking directly on your screen to submit your answers. And here's the question. Within your organization, Which way of using social determinants of health data are you considering? Global use, look at population to create programming and allocate resources. Local use, help pharmacists tailor consultations to meet individual needs, patient needs. All of the above? We don't know yet. Within your organization, which way of using social determinants of health data are you considering? Global use, look at population to create programming and allocate resources. Local use, help pharmacists tailor consultations to meet individual patient needs. Both of the above, or we don't know yet. So the results are in. And Erin, would you like to address?
Yeah, absolutely. So it looks like leading is the local use, so at the pharmacist level, helping individual patients with 33%. And then global use is about 12%, and then I love to see that both is being considered at 32%. So actually, when I've talked to pharmacies, the most common use is kind of starting at that global or corporate level and figuring out what program they need. And then once they become more comfortable with using social determinants data, they push it down to the pharmacist. But it's great to start either way, whatever you're most comfortable with. So as we come towards the end of today, I just wanted to say that however you choose to begin using social determinants, there's value to be gained. It's estimated that challenges with medication adherence cost the U.S. healthcare system anywhere from $100 to $400 billion a year. So there's a lot of potential savings and other medical-related costs and potential pharmacy revenue if they do take their medications as prescribed. It's also estimated that medication non-adherence contributes to as many as 125,000 premature deaths each year. So improving adherence is in line with the mission of healthcare organizations to improve the health outcomes of their patients. As the pharmacy industry continues to shift more and more to value-based care incentives through CMS star ratings, DIR fees, and risk-sharing contracts with payers and providers, social determinants of health can provide that much-needed view into what challenges patients are facing when it comes to achieving medication adherence and optimum health outcomes. Using social determinants of health to create community-level programming and allocate resources appropriately at the region, district, store, and individual level is critical to providing better care management, which can lead to optimized financial outcomes under these value-based programs. It also can lead to more loyal customer base who appreciates the personalized consultations. Rich and I hope today has given you a lot to think about, and we welcome continued conversation. For now, let's start the conversation by opening up the session to your questions. Amanda?
Thank you so much for that informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found on the right-hand side of your presentation window. We will try to answer as many questions as we can. And here's our first question. How do you calculate social determinant of health scores? Are there standard scoring guides, or are all these priority by health provider?
I'm sorry, you cut out. Could you repeat the question?
How do you calculate social determinants of health scores? Are there standard scoring guides?
Yeah, so there's really not a clear standard yet on how to calculate social determinants of health. Within our organization, we actually have a team of data scientists that have looked at varying factors about people's lives, what we consider the social determinants, and then they compared that to actual claims data to see health outcomes like medication adherence, and then we're able to look for correlations and take the ones that were basically the highest correlating to different factors and build out those risk prediction scores. I think one of the interesting things we've seen is that the same social determinants that impact medication are not necessarily the same ones that impact whether or not you're likely to get readmitted, or even the same ones that impact whether or not you're likely to be motivated to take care of your own health. So it's really important to look at the factors that have the highest impact on the specific outcome you're trying to address.
Great, thanks, Erin. Here is our second question. Does this pay for performance apply to patients with private insurance, such as Aetna or United Healthcare?
So I'll take a stab at this one. Broadly, the answer is absolutely yes. There's pay performance now trying to move to pay for quality. What we've really seen is this whole journey towards paying for quality evolved from basically performance-based bonuses to all the clinical quality measures that you see here today. So we didn't get into all of them, but in the health plan world, there's HEDIS as well as a bit of STAR. In pharmacy, there's STAR that is being utilized to evaluate for the Medicare population whether or not quality is being delivered. Then, and relates to pharmacies, you're seeing that in the form of performance measurements or metrics. And then in hospitals and physicians, they're seeing it in macro and MIPS. Long story short, a lot of these measures are the same, and they're designed to overall, despite whether or not you're Medicaid, Medicare, or a commercial line of business, be able to go ahead and show and demonstrate quality is occurring. So, for instance, if we talk about STAR and compare that to HEDIS, two different measurements for audiences, about two-thirds of the measures are still the same. When you talk about the medication adherence, much of the stuff that is being looked at within STAR for pharmacies or prescription drug programs, which turn into performance measures for STARs, all are being shared across all those envelopes. So while there's significant tweaks to each division and significant tweaks among commercial payers versus public ones, by and large, there is also significant agreement on a core set of measures which are being evaluated. And those oftentimes get turned into your alternative contracts and various other measures that are being utilized both from a public sector standpoint as well as a commercial standpoint.
Thanks, Rich. We do have another question here. How do you recommend we gather information on social determinants of health for our population as a starting point?
Yeah, that's a great question. So there's a lot of different methodologies that you can use. One of the easiest ways is to work with a vendor that has third-party data. A lot of information can be gleaned from public records, and it's one of the quickest ways to get hundreds of different pieces of information about an individual, and ideally work with those groups also to then understand their predictive accuracy. But then also it can be driven at a survey level as well. I know a lot of organizations do that. A lot of times what we recommend is you look at kind of third-party information and really zero in on the areas where individuals might need help, and then use additional survey questions to really have that conversation with the patient and identify what they consider their highest needs to be so that it ends up becoming a really joint effort to come up with that care plan.
I'll just add that real briefly because I think Erin's answer was quite good. That there are a host of sources of information, and usually combining two are the best. For instance, there is a whole series of Z codes within ICD-10, which there's a lot of excitement in the industry about being able to utilize, which the physician or dispenser encounter could describe that there is a problem there. The issue with that is those are rarely used today. And survey data is not available across all patient populations, matter of fact, in very small pockets. So usually it's good to combine that with an objective third-party data source to try and get a more comprehensive picture of all the social determinants and barriers that exist within your populations, so you could decide overall what things can we impact, and then dive down to specific individual patients and uncover what's driving their behaviors.
Great. Thank you both. Here is another one. I had participated in the past distributing a survey to determine social determinants of health in my patients. Even in some of our most loyal patients, I received some hesitation in answering personal questions such as housing, money, etc. Do you have data to support this type of pushback from patients? Is it common?
Yeah, there's the TV show that used to be on called House, where he says basically everyone lies. And I don't want to be that mean. I'm not that negative. But we do see interesting things. For instance, we've had clients who've tried to go ahead and gain more insight into housing stability and ask for addresses, and the address will come back as a vacant plot of property, which is indicative of the fact that the individual patient is probably homeless or bouncing from sofa to sofa and made up an address because they're too embarrassed to admit this particular situation. So, patients are unique, and depending on their situation and the individual, they might not answer all aspects of this as truthfully as possible. That's again why we do believe that survey data is useful, but needs really to be supplemented with objective third-party data that could ascertain, at a high level, what the patient's condition, socioeconomic status might be.
Yeah, I would say, just to add to what Rich said, is we've looked at a number of surveys, and especially with the millennial population coming up, you're finding that the younger generations are a lot more comfortable sharing that kind of information, and they don't have as many of the same privacy concerns that we've historically seen. So I think you're going to see a shift where they are willing to share more, or what's more likely is they're going to be more comfortable with you pulling information on them where it doesn't have to take up their time, but they're comfortable with you having the data if it means that they're going to get personalized care. So I think that fits in well with what Rich was talking about, which is surveys certainly can be useful for digging deep on items, but if you kind of want to help zero in on those, a lot of times it's useful to have some external data to find those focus areas first and then really focus the conversations. I know in my personal experience, I went to a physician and they had me fill out like a 400-question survey, or at least it felt that wrong, and by the end I wasn't really paying much attention or probably putting as much heart into it as you would have wanted if you were planning to use those items. So that's where it's really, you need to ask targeted questions to really get to the heart of it in order to be successful with them.
All right, here we have another question that has come in. What is the best way to find the resources available in the community? Is there any group or agency that would be a good community contact to contact first to start identifying community resources?
Yeah, that's a question that a lot of our customers struggle with, is how, once you have identified what the patient needs, how do you get them connected? So there's, of course, the government websites and organizations like the CDC and the World Health Organization that now have entire pages dedicated to different types of social determinants of health and what kind of community resources you can look for. And then we're starting to see care coordination networks pop up. I can't speak specifically to either of them, but I have heard of Aunt Bertha and Unite Us as two potential options that you could look into, and I'm sure there are others that are really designed to help to target those referrals to community resources. We also see a lot of organizations starting to create their own programs if they see a large enough need within their population. So that's where it can be really helpful if you look at kind of an organization-wide level and understand what populations need different help, that you can start to think about, are there any programs that it would be more beneficial to run internally?
All right, and here is another question. What type of solutions based on social determinants of health is required by payers?
That's, there's the old adage, if you've been to one health plan, you've been to one health plan. Obviously the payers, when they're contracting and doing business with the public sector, so Medicare, for instance, federally run, there's unique standards across all that within, you start to see within STAR, which are required for social determinants of health to be utilized. But when you start to get to the commercial population, so employer-based insurance and so forth, it's more a matter of specifically each health plan and what they're capable of and what they have in place. Aaron just alluded to what social determinants have they built in-house. I'll give you an example. Some health plans out there are seeing that health can be improved by simply providing non-emergency transportation to get some of their members to the pharmacy or to the clinic. Instances where they need transportation, but it's not at the ambulance level, are starting to be built. And then there is, Medicaid, which is state-run. And state by state, there are different requirements out there in regards to the use. For instance, in the state of New York, they require that any ACO out there, so alternative contract with risk-bearing entity between a hospital system and a health insurer, that at least one social determinant of health is being met, and you see that throughout many other states. So if you see the health plan managed Medicaid MCOs out there, they're very accustomed to getting RFPs from states that indicate that there is a minimum requirement on social determinants of health. In many cases, they're starting to be prescriptive as to which social determinants of health should be included. Going back and finishing up on commercial health plans that focus on the employer-based insurance or individual insurance, they're trying to kind of assess the entire population and look for the frequency of at-risk members and density where they reside, and start to determine based on those two things which social services makes the most sense for them to either partner with or build out themselves. We see a lot of research being done at that phase right now.
All right, thanks, Rich. It looks like we have time for a few more questions. Here's one. How many data signals do you have to determine socioeconomic data, and what's the frequency to which you keep it current? Can you provide additional details around these signals?
Yeah, absolutely. So when you look at social determinants categories, it can be anything related to economic stability, anything related to your social support system, your neighborhood and your built environment, your access to health care, as well as education levels that often indicate kind of your health literacy levels. So when you consider there's really 5 high-level categories, and then within that there's hundreds of different things that you can consider about individuals, we take a lot of that into consideration when we are thinking about social determinants of health. So it's not just any one factor about an individual, but it's looking at all of them in combination. So one example is, traditionally low income often has kind of a negative impact on health outcomes. But if we find out that you have low income but you're also in college, that starts to then balance out the picture because it may be a temporary situation. So we do look at all of that in combination when we're coming up with the way that we view social determinants and come up with those risk scores.
Yeah, I'd add on top of that to the explanation, it just within the economic security or instability category itself, it's one thing to know that a patient might be making, estimated less than $20,000 a year and probably be Medicaid eligible. But it's another thing to know that they live in a household with 5 other people and the combined household income is north of 6 figures. That dramatically changes your view of them. Likewise, if someone is socially isolated, they live in a household by themselves and don't have access to a car, you worry about their ability to go ahead and get to appointments, like, for instance, the medication therapy management. However, if you could ascertain that they have close associates or relatives within 10 miles, that quickly changes the image of whether or not they could have caregivers available to them to help them manage their health outcomes. So a variety of things like that, not only look at what they are today, but where they've been historically and who they're associated with, gives you that richer picture to give you a true understanding. And getting back to the original point of the question, it requires as many signals being brought in as possible. And they tend to come in, census data happens only when census occurs, but financial information can come in several times a day, right? You look at neighborhood information and healthcare access. The points there in regards to, for instance, your access to a primary care physician or a hospital nearby, that updates every few months and so. So all of these have to be taken in totality. And the good news is there's many different sources out there you could gain. The challenge is making sure that you aggregate sufficient ones that you need in order to basically target or build and identify, and let's say medication adherence or motivation, you have sufficient to drive performance of that model.
Okay, here's a question. Do you think there is a gap between the drive to deliver better healthcare interventions through social determinants of health and the tools currently available? What part do pharmacists play in addressing this?
Yeah, so I actually do think there's a gap between the recognition of social determinants of health and the value it brings and then being able to act on it. Organizations like ours are working very hard to get the right insights into the right hands and then partner, with community resources on your end to really be able to address those. But this is an evolving market, and there's a lot of exciting things that can be done, but it also takes some kind of early adopters and people willing to try different things. But in a lot of cases, the tools have existed for a long time. So there's been community resources, and there's been an understanding that social determinants help. I think with the value-based programs being implemented, it's driven a lot of good interest around it and a lot of good attention around it. So I expect that the tools will continue to develop. We're certainly doing our part, but looking at others in the industry as well to help on the care side. Rich, anything you'd like to add?
Yeah, just one piece, which is just, I think all the capabilities needed to effectively deliver on the promise of social determinants of health in pharmacies and improving outcomes are there today. It's a matter of sitting down and figuring out how to engineer them to work in that workflow together most appropriately. And that's, I think, probably the key learning, right? It's one thing to identify who's at risk and then understand why they're at risk. But now you need to get that information in existing workflows to people at the point of their care. And that's the remaining last step of engineering that really has to be done, and has to be done in a thoughtful manner. Because as we said earlier, if you met one payer, you met one payer. Same thing with pharmacies and everyone else. Lots of unique systems and ways, and so we need to find a way to distill this down to the most basic level so it can be ingested in whatever system you have and delivered at the right point.
Yeah, that's a great point, Rich. And one other part to the question that I've missed before is what part do pharmacists play? One of the things that brought to mind for me was we hear a lot from payers and providers that the pharmacist is becoming an incredibly crucial point in the overall healthcare journey to be able to improve these health outcomes, and it's because the pharmacist sees the patient a lot more in person when they're picking up medications once a month or whatever the case may be than they're necessarily interacting with a care manager or even a provider. So I think the pharmacist has a growing role in ensuring those health outcomes, and that's why you're starting to see more of those risk-sharing and value-based contracts coming into play.
All right, here's a question. In addition to traditional pharmacy services, we now have care clinics in many of our stores. Can social determinants of health help more broadly than medication adherence?
Yeah, absolutely, and this is a great question. Obviously, there's been a move to include lots of clinics, whether they're supplied through the pharmacy or in conjunction with a local provider, to bring in those non-urgent capabilities into the pharmacy and transition a retail into a clinic environment as well. As you start doing that and you start looking at the population around you to ascertain that motivation score I talked about, the motivation prediction, who's likely to participate in their own care. Erin made a fantastic point earlier where she was showing the people who are just below the 80% of prescription filled needed to make sure that they were considered to be medically adherent. Well, think for a moment if you were trying to get people in for their annual physical or for the comprehensive medication therapy, comprehensive medical review, medication therapy management, my apologies, or any of those other services which could be conducted in those services. And think, okay, who is just below the threshold of someone who would be come in on their own initiative? Now that I've identified those people, what can I do from an outreach perspective to try and convince them to come on in and get that taken care of? Doing so not only creates a better retail experience and ease of clinical engagement with the member. It's much easier to go to a pharmacy to have these services done than into the hospital or in the physician office waiting room, right? So there's very much an enjoyment factor there, but also it delivers a better quality experience and quality rating because you've gotten that person into for this preventative screening or for this treatment, and now you can record it correctly within your quality ratings, which leads to better score and eligible reimbursement for you. And because we're making sure this individual patient is being treated, leads to better outcomes for them. So utilizing social determinants of health to identify those people who might not come in to get this particular, whether it's a treatment or whether it's a screening done in of their own, but with a little bit of insight into their socioeconomic status, you could align a service to get them in. You could do a tremendous service to improving their health while improving your clinical quality score.
Great, here's a question. When it comes to the technology, can social determinants of health be incorporated into workflows today?
Yeah, so Rich talked about this, but they absolutely can be. We would highly recommend they be integrated into pharmacy management systems as part of the normal flow of interacting with a patient, and that can be done in your existing systems through integrating APIs, or if you want to get information behind the scenes and then load it into an existing kind of UI format, you can do that as well. So there's a lot of different ways that you could have it present within your existing workflows.
All right, we have one more question. Do you provide just the social determinants of health risk score, or do you also provide the underlying individual factors that lead to that score?
Yeah, so we feel it's important to provide not only the risk, so you saw some examples where we're like, you know, this is 25% likely to adhere to medications or 75% likely to adhere to medications, but also to provide those actual examples of the barriers that are contributing most to that risk. We actually, you know, within our vernacular call it care drivers, but there are specific social determinants that it's important to surface so that if you address those, you have the greatest chance of being able to move the needle on that quality metric.
Great, thank you so much, Erin. And unfortunately, we're out of time today, but I wanted to thank the audience for attending and for participating in today's event. I would also like to thank our sponsor, LexisNexis Risk Solutions, for making today's educational webcast possible. You will receive an email from Managed Healthcare Executive or Drug Topics alerting you when the webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you all for joining, and we'll see you next time. Goodbye.